Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. In this episode, Dr. Cassandra Vonnes, a gerontological nurse practitioner and member of the GAPNA Communication Team, talks with Dr. Alice Bonner, a nationally recognized leader and researcher in gerontological nursing, and a member of the Gerontological Advanced Practice Nurses Association. Dr. Bonner discusses her inspiration to become a gerontological nurse, her efforts to support older adults through the implementation and improvement of age-friendly health systems, and her dedication in advocating for older adults to receive optimal care along the healthcare continuum. We are pleased to present Dr. Vonnes' interview with Dr. Bonner.
So, hello everyone, and welcome to our first GAPNA Chat in our Series 2 of our podcast for 2022. And we have with us today Dr. Alice Bonner. She's currently the Director of Strategic Partnerships for the Center for Innovative Care and Aging, which is a collaboration between Johns Hopkins, Bloomberg School of Public Health, and the Institute for Healthcare Improvement, which she serves as a senior advisor. Welcome, Dr. Bonner. So first thing, to get to know you a little bit, what would you say to the 18-year-old Alice? Now that you've become a champion for older adults in acute care, long-term care, and in the community.
Well, that's very kind. I don't know that I'm a champion any more than any of your listeners, but I've been a GAPNA member and a previous GAPNA board member in the, remote past. So I know the organization very well. And I believe that as far as what I would have told the 18-year-old Alice, that was before I knew anything about nursing and anything about nursing homes, because I had really had very little exposure. But, I would say your career as a person who's interested in older adults, either through nursing, through health professionals development, or through community work and public health, your career can take a lot of different twists and turns. And some of it is because of things that you can control and manage, and other things just happen along the way. And so, I'm 65 now, so I certainly didn't know that when I was 18 and couldn't have predicted it. But I would just say to people who are more junior in their professional growth, who are listening in today, yes, you should take advantage of every opportunity. Yes, you should think about places where nurses have not gone before and opportunities for nurses to step in and provide high quality health care and collaborate with older people and support them and respect them in ways that has not always happened with our health system in the past, which has a history of being a little paternalistic sometimes. So those are some of the things that I would say. But I give those examples because when I went to nursing school back in, 1979 and 1980, people weren't talking about nursing homes almost at all, even though there's, 1.5 million people who live in nursing homes. And when I told people that's the work I wanted to go into, a lot of them said, well, why would you do that? And, why would you want to go into those places? They were so misunderstood. And people didn't recognize the incredible leadership opportunities for nurses that are now, very clearly a part of not only nursing homes, but assisted living residences and continuing care retirement communities and senior living and all that. So probably a longer answer than you wanted, but I would say look for opportunities that may have been overlooked for a long time, and you will find things where you can really make a difference. And that's very gratifying to a lot of people.
And you worked in long-term care as a nurse's aide early. And how did that inform your perspective then when you became a nurse?
So when I first started, again, I was 19 years old. I was in college, ran out of spending money, and I really needed a job. And somebody on the faculty said, well, I think they need nursing assistants, at the nursing home where his mother was. And I literally, because it was back in the late 1970s, you didn't need to be certified. So I literally walked in, filled out an application, and they would have almost started me the same day, but they gave me a few days. And I did not know anything about nursing homes, how older people who live in those environments, what it is that they need, what it is that they want, what matters to them. And so it was just like, drinking from a fire hydrant for me. It was just all new. And what was really impressive to me working as a nursing assistant was how many hours a day the care that we provide for older people, for one another as we age, is provided by nursing assistants. It's not provided by nurses. The nurses in those days were, passing meds, using a med cart. They were doing treatments and they were doing a lot of paperwork, and they weren't really interacting as much, but they did teach me a lot. And I could see that they were the leaders in the nursing home. We almost never saw physicians in those days. They almost never came to nursing homes. Thankfully, that's changed a lot over time. And we now have medical directors who are very involved in attending physicians, geriatricians in areas that have academic health sciences centers and so forth. But there's still a lot of parts of our country where there are very rural areas where nursing homes are spread out. There's not a lot of, other interactions with like the hospitals or the medical practices or the community organizations like the senior centers and the area agencies on aging. And people, in the health system don't always know that, area agencies on aging provide this rich array of services and programs to older adults in the communities. And so in one of my more recent jobs where I was, working in the Division on Aging, the Executive Office for Elder Affairs here in Massachusetts, it was another whole world that opened up to me because I didn't know about all these home and community-based programs. And many of the folks listening to this podcast, if they're in GAPNA, are very possibly working in people's homes, working with home health. That's where the growth is in nursing, careers these days. So again, it's just an opportunity to say, whether it's nursing homes, home health, PACE programs, again, health centers that are within senior living communities. These are all places where nurses and nurse practitioners, again, GAPNA is about advanced practice nursing, where advanced practice nurses can play not just a role, but a leadership role in directing the quality of care and quality of life with older people.
With your wealth of experiences, it just seems a perfect fit for you to become a senior advisor for the IHI and their age-friendly system. How did that come about?
So I had been in the state government for almost 4 years, and I loved the work. But, for those of us, besides myself who've been in state government, there's a lot you have to deal with. So, I had come to a point where I thought it was a good time for me to do something different. And I wanted to step away from my government roles because I'd been in state government. I had been at CMS and federal government. And, the Institute for Healthcare Improvement is an organization I've followed and known for a fairly long time. Also, when I was at CMS, Dr. Don Berwick was the CMS administrator. So I had the opportunity to actually work with him at the federal level. And that's when we had a group of advocates that came to CMS, and they wanted Dr. Berwick to do something to address the very high rate of antipsychotic medication use in older people living in nursing homes. And this was, there was lots of studies done to demonstrate that there was no clinical indication for a lot of these medications, and that they were being used to sedate people in some cases, not all cases, but in some. And so there were opportunities to really get in there and see, because the rate of antipsychotic use was up to 40% in some nursing homes, which is just, really high. And again, there was just no clinical indication. So Dr. Berwick had an opportunity to say to our division at CMS, I want you guys to take the lead on this and run with it. And we had lots of national partners, including GAPNA. So GAPNA was one of the organizations of many that came together. And, we did webinars and podcasts, and we worked with lots of nursing homes all around the country and lots of experts. And, a lot of people said, oh, it can't be done. The physicians are going to say these people need these medications, and the nurses are going to say they need them. And we did hear that from a lot of people. So it was not easy and it was not fast, but that was, back in 2011, 2012, and that CMS national partnership is still going today. So again, a lot of Dr. Berwick's vision on that and a lot of hard work by lots and lots of people, I'm sure some of whom are listening on this call today. But the reason I'm mentioning it with IHI is Dr. Berwick was the founder of IHI and really the visionary behind it. And IHI does a lot of work on quality improvement across settings. And so my interests are not just nursing homes, but nursing homes, PACE programs, home health, hospital, emergency departments, and others. And so it seemed like a good opportunity for me that we could do more around care with older people and really promoting wellness, health, wellness, high functionality, and capacity for the quality of life that all of us want as we get older. And so again, at IHI, we now are working on age-friendly health systems, which I know you'll talk more about. But, for me to be entering IHI at a point where age-friendly communities and age-friendly health systems were such a big part of the organization, that was great for me because I can come in and say, well, here's how we might think about nursing homes within age-friendly, or here's how we might really approach assisted living. And there's so much work still to do. We've only just scratched the surface with age-friendly, but it is catching on, and there's a lot of momentum in the organization and outside the organization from other entities that are joining. And so we have over 2,700 health systems already recognized as being age-friendly, which means they've met certain criteria. So we're encouraged.
And tell the listeners a little bit about, with this huge umbrella of quality care for older adults, how did the IHI drill down to the 4 M's?
Great question. So, it was before I joined. So I joined in 2019. So they'd been doing that for about 2 or 3 years before I was there. But what they did was they reached out to a couple of what they call pioneer health systems. So, these were health systems where they already had professionals that were doing this to some degree. So they either had geriatricians or geriatric nurse practitioners or geriatric pharmacists or a whole team of people, that were really interested. So they went to Yale New Haven Hospital. They went to Anne Arundel Hospital in Maryland. They worked with Kaiser Permanente. They worked with the Providence Health System and a few others around the country. And so there were these 5 pioneer health systems that came together and said, we want to do this. So they had the will, they had the expertise, and they had the interest in moving forward. And so they came together, and there was a very significant literature review where, all of the scientific literature was looked at, the government reports, et cetera. And they looked at what are the essential elements of care with older people and the care that older people want, that they tell us that they want. And that's where they culled down all of the things in the literature. There were initially something like 110, and then they culled them down to like 20, and then they got down to the 4 essential ones. And so the 4 M's, because they all start with M, are what matters. So what matters to the older person: medication, mentation or the mind, and that's dementia, delirium, and depression, and then mobility. And then there are sites that have added a 5th M, like multimorbidity or music. Some have added music. The fundamental platform is the 4 M's, and we pretty much stick to that. And, it's got to be that it's based on a set of, evidence-based principles, because everything in age-friendly is based on evidence-based or evidence-informed work, that it causes no harms, and that it is absolutely consistent with and following what matters to the older person, not to their daughter, not to their, nephew or any care partners, but to the older person, because, very often that's not the same as what's important to a family member. So anyway, But the 4Ms, has been tested in those 5 pioneer health systems, refined, studied by health economists. So one of the common questions IHI gets is, well, how much will it cost our system to do this? And the response is there are some costs initially and upfront, but they're not significant. The training time is not significant. And in order to demonstrate that, we actually worked with a health economist who designed business cases. And so on our website, you can access the business cases for hospitals and ambulatory practices. And now we're working on business cases for payers and health plans and nursing homes, for example. So, the 4Ms have been tested in hospitals, ambulatory practices, nursing homes, and convenient care clinics, such as we see with, some of the pharmacy chains. And we're working with home health accreditors on, how we might do recognition for home health. We recognize PACE programs within ambulatory practices. And we have a lot more, settings of care where we really want to be able to recognize whether or not they're meeting the criteria for age-friendly. And people can go on the IHI website and pull down any information that they're interested in about how do you join an action community to be with other peers who are working toward age-friendly recognition. How do you do it on your own? If you just say, hey, we're a big health system, we can do this on our own. We totally agree. So we've got some, information on how you can do that. We've got materials, tools and materials that you can download so you don't have to invent any of those things. Again, if it's an evidence-based tool you're looking for around something like mobility and you don't have one, just email us and we'll share what we have. So trying to really build this learning community. So again, we've got over 150 organizations now in the current learning community. We call it the action community. 33 of those are nursing homes. The rest are hospitals and ambulatory practices. And we just had 2 really great calls this week with the action community. And I worked on the breakouts for the nursing homes. And boy, the chat was just going a mile a minute. People had lots to share. So that's in a nutshell what we're doing with age-friendly health systems. And then some of the people who are listening today may also be working on age-friendly communities. And that's, if you're an employer, how do you become an age-friendly employer and get recognized for that? If you're a university or college, how do you become an age-friendly university and get recognized for that? And so there's lots of these opportunities out there for communities.
So that's wonderful advice and that was going to be my next question. What does the APRN do if he or she is maybe in a primary care practice that, maybe also does some nursing home rounds, one day a week? This is sort of my model when I was younger. How would they get involved? Just join an action community, go to the IHI website?
So the best way to join an action community to really get the most out of it would be for an APRN to work with the organization that he or she is employed with. So, again, work with that group practice. And your model was exactly how I practiced for 30 years. So I get it. So, work with the group practice that employs you or the nursing home that employs you or contracts with you, the home health agency. Go to them and say, we heard about age-friendly health systems. We think that we could get recognized as being an age-friendly health system. A lot of people say, hey, we're already doing a lot of those things. We already ask people what matters to them as part of advanced care planning. We already review all their medications and look for high-risk medications. We already assess or screen for dementia and delirium and depression. And we do a timed up and go for mobility. I just really quickly went through things. It's more than that in those, 4Ms, but a lot of people already do some or most of those. And so for an APRN, if you convince your organization that joining an action community would be useful, the action communities are 7 months long, but it's only 1 hour each month. So it's not a huge amount of time, and different people can join. Doesn't have to be the APRN every single time. And, again, at the end of the 7 months, you've got all of the tools, the materials, the guides, the manuals, shared with you. And then you're really in good shape over those 7 months to work toward the formal recognition if you're interested in that. And there's not a lot of data burden because we've really intentionally kept that low because people are already required to collect so much other data. So, you can, after a point in time, let IHI know how many older adults that are in the population who are eligible, receive age-friendly care with all 4 M's. And it's not that hard to track that, but it's a way that you can demonstrate over time that your numbers are increasing to show that you are reaching more people with age-friendly care. And that's a really positive marketing message too. If you're in a competitive environment with lots of nursing homes in a particular area or lots of hospitals that are competing, for you to be able to say that your organization is age friendly, that could really attract members. Same thing if you're part of a health plan. If you're an APRN working with a Medicare Advantage plan, there's usually a lot of competition with other MA plans. And it's a great way to be able to say, we're age friendly. And so this is a good plan for our members because here's all the things we do that are age friendly focused. So anyway, you can always go on the agefriendly.org website for IHI. So if you just, Google IHI and age friendly, it'll pop right up. And you can see the page that says join the movement. And again, an APRN can join on their own, but a lot of the questions and a lot of the kind of work in between the sessions is really for the team. So our general advice is if you can, join as part of a team from a setting where you're practicing.
When you're talking about evidence-informed care, it sounds like the IHI gives us a nice foundation of some process measures that we need to get in place for the older adult. Now, if you're part of a practice or you're having to collect MIPS measures or other things that go along with practice requirements, does the IHI help you, carve out some outcome measures that you can also report?
Mm-hmm. Absolutely. You're right on the money. We have a slide in our slide decks that has all of the process measures and some of the outcome measures. And because the settings are different and have different requirements, if you're a health plan, there's HEDIS measures, MIPS measures. If you're a nursing home or a hospital, there's CMS STARS measures for quality and other things. And some organizations, whether they're a hospital freestanding or they're part of an ACO or they're part of a value-based provider payer arrangement, they have their own sets of utilization measures. So, rehospitalizations, readmissions, ED visits, specialty visits. And so they want to track those things as part of their quality package and also, looking at utilization and trying to figure out if you can cut down on unnecessary acute care visits, then you can take those dollars and redeploy them into preventive care and vaccinations and outpatient visits and so forth. So I would just say, yes, we have outcome measures as well as process measures. We also have structural measures on things like workforce. So, some organizations want to be tracking turnover, things like that, open positions. So all of that is possible. We encourage all of it. And we work individually with organizations and APRNs and other folks, chief quality officers, to be able to say for your organization, what's the most useful data that you want to collect that you can act on? And let's not have you collecting anything that you're not going to act on, because that's a waste of time.
It's sort of like the serenity prayer, right? The things to know that we can make a difference in, but we need to be wise enough to know
absolutely
the things that we can't, that are not in our wheelhouse to change. So very, very good advice. If you had to drill down to an elevator speech, because I think that's what, we obviously have the heart. The GAPNA team, we already have the love, the compassion. We're here for a reason. But how would we present the age-friendly model to the C-suite if you're in a large institution? How would you sell that in a modified elevator type speech?
So we have lots of coaching exactly to do that. And we would love to be contacted by any GAPNA members or non-members, anybody who wants to get that coaching. Boiling it down to the most basic, I think we often say that age-friendly care is what every person deserves and wants for themselves. And it means that the care is delivered to people with every encounter by every team member or staff person or health professional to people at every age. And it's not just about being older, it's for people at every age to receive age appropriate care. And the most important thing, as I said earlier, is that it's about what matters to us as we get older, which a lot of times when you start asking the questions about what matters and you say to people, what do you really hope to achieve in this, hospital stay or this nursing home stay, or, what's the most important thing to you each day? What do you want to be able to do every day? And people start talking about things, and a lot of them are not even health related, but it's what's important to them. It might be related to family. It might be related to activities outside of the health setting. So again, age-friendly is the kind of care that we would each choose for ourselves if we were the ones in charge and determining how the healthcare is delivered and how we participate also. So many older people say, if you start asking them those what matters questions, they'll say, no one's ever asked me that. No one, and they'll start by saying, I love my doctor. I love my doctor. She's great, but she's never asked me those questions. And it would be the same thing of a nurse practitioner. So not differentiating there at all. It's any primary care person. And in the environment where I practiced most in nursing homes, this is such a great role for nurses. This is a great role for RNs in nursing homes and assisted living, because they're there 24/7, or if not 24/7 in assisted living 5 days a week. They spend a lot of time with older people and are in a great position to do that. So I know we're almost at time, and I hope that this was helpful to GAPNA members. And I hope most of all that people who are in any way interested in this, even just a little bit, we'd love to hear from you and talk with you more.
Thank you. This has been just an incredible conversation, and we will have those resources available attached to the podcast. So hopefully you've enjoyed Dr. Vonnes' conversation with me about age-friendly. Do you have any parting words for our audience?
I will just say that, leadership is what is making a difference in this work. And leadership is coming very often from advanced practice nurses like all of you who are listening. And don't think it's somebody else. It's not. And nobody's going to tap you on the shoulder and say, why don't you lead on this? Except maybe somebody like me is going to say, go do this. And we really hope that you will do it, because you are part of the solution and we need you to do it. So, sometimes people say, well, I don't know how to start. And the answer that we give is, you just need to start. You can start anywhere, but decide that you're going to be part of this, decide you're going to get more information. That's how you start. And you go to the website and see what's there and email me, and I'll be happy to follow up with you. But we really hope advanced practice nurses will continue to be the great leaders that all of you are. So I appreciate your listening in today. And thanks to Cassandra for inviting me.
Well, and thank you. We all have our marching orders now, and don't be afraid to jump in somewhere. There's lots of guidance there to take you on that journey. So thank you again, Dr. Vonnes, and thank you all for tuning in for GAPNA Chats. Thank you.
Thanks so much. Bye, everybody.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. Dr. Alice Bonner is the Director of Strategic Partnerships for the Center of Innovative Care in Aging, a collaboration between the Johns Hopkins Bloomberg School of Public Health and the Institute for Healthcare Improvement. Dr. Bonner's work focuses on supporting and empowering older adults to be able to age in their communities, creating and improving age-friendly health systems, promoting dementia-friendly communities, and support for caregivers of individuals living with dementia, working to prevent elder abuse and mistreatment, and advocating to end elder homelessness. Previously, Dr. Bonner was Secretary of the Executive Office of Elderly Affairs for the Commonwealth of Massachusetts. Dr. Cassandra Vonnes is the Nurses Improving Care for Health System Elders Niche Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association Communication Team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.